Hello and welcome to this virtual class on atrial fibrillation. My name is Shelley. I'm a nurse at the Heart Institute and I work with the electrical specialist, the electrical physiologist. The purpose of this class is to give you a broad overview of all things atrial fibrillation. We'll look at how the normal heart functions, how it differs in atrial fibrillation, some of the ways that we do our diagnostic testing, some medications and treatments for atrial fibrillation as well. And we'll look at the risk of stroke with atrial fibrillation and how to deal with that risk, how to prevent stroke. And we'll look at the algorithm CHAD65 that we use to determine an individual's risk of stroke with atrial fibrillation. And we'll also look at some lifestyle management for atrial fibrillation and some tips to live well with atrial fibrillation. So first we'll look at the normal heart. The heart is a muscle. It functions as a pump to circulate all the blood. And I have a video I'll show you after, but just briefly, we have the right atrium, the right ventricle, the left atrium, and the left ventricle. In the left atrium, there are 4 pulmonary veins that bring the blood from the lungs back into the heart after being oxygenated. And anatomically, these structures are important because we know they play a role in the development of atrial fibrillation. So I'll go ahead and show you a video now.
Today, we want to talk to you about what atrial fibrillation is, what causes it, and how it can be treated.
We believe that the more you know about your condition, the better prepared you will be for its treatment. And with that knowledge will come greater confidence and peace of mind.
Now, before we talk about atrial fibrillation, let's take a step back and look at the normal functioning of the heart.
The heart is a muscle whose function is to pump blood through the body. It has 4 chambers, 2 upper chambers called the right and left atrium, and 2 lower chambers called the right and left ventricles.
Each of these chambers has a different function. The left ventricle pumps the blood out to the entire body, from the heart to the head to the toes. The blood returns through 2 large veins, entering the right upper chamber called the right atrium.
From there, it passes to the right ventricle, which pumps the blood to the lungs. The blood then returns to the heart from the lungs via the 4 pulmonary veins, which drain to the left atrium. The left atrium is then responsible for filling the left ventricle, completing the blood flow circuit.
The contraction of the heart muscle is driven by organized electrical impulses, much like a spark plug drives an engine. The normal heartbeat originates in a pacemaker-like structure in the right atrium, called the sinus node, and it spreads evenly and uniformly through both the right and left atrium, causing them to contract. The upper chambers, atria, and the lower chambers, ventricles, are electrically insulated from each other where the valves separate the upper and lower chambers. Electricity can only reach the lower chambers through a special conducting system called the AV node that delays the electrical impulse briefly to permit enough time for blood to flow efficiently from the atria to the ventricles before the lower chambers contract. Obviously, this is all a delicate and precisely timed process, and it happens 50, 60, or more than 90 times a minute, depending on your activity level.
When the electrical impulses become disorganized, it results in loss of organized contraction of the atrium. This is called atrial fibrillation. The atrial muscle stops contracting and begins quivering, known medically as fibrillating, which results in the atria no longer pumping blood into the ventricles. This results in highly irregular contraction of the ventricles, which can cause an uncomfortable sensation. This results in 2 mechanical problems. The lack of coordination between the atria and ventricles diminishes the effectiveness of moving blood with each heartbeat. This may make you feel fatigued or short of breath. Blood in the atria becomes stagnant, which can lead to the formation of blood clots. These can dislodge and go to the brain and cause a stroke or other problems.
So, what causes atrial fibrillation? It arises most often from
So I hope you now have a better understanding of how the normal heart functions, the normal electric activity within the heart, and how it differs in atrial fibrillation. So we've talked about most of this in the video. Atrial fibrillation, it is also called atrial AFib or AF. In the medical field, we like abbreviations. It is the most common form of heart rhythm disorder or arrhythmia. It is definitely more common in the older population. By the age of 80, at least 1 person in 10 will have atrial fibrillation. Less common in the younger population, about 1 in 1,000 if you're less than 55 years old. That said, we do see people from all ages, from in their 20s right up into being elderly. So just as a brief review, it is an electrical short circuit within the top chambers of the heart, and the atria are no longer doing a nice smooth contraction, rather they're quivering like a bowl of jelly, and this affects the blood flow through the atria. I'll just briefly mention atrial flutter because some of you may have it, not atrial fibrillation. They are very closely related. They're cousins, really. And atrial flutter, if you have typical atrial flutter, I'll talk about it just because it does come from the right atrium rather than the left atrium of atrial fibrillation. And this is an important distinction for typical atrial flutter because if you're going for a procedure, it is less involved than an ablation for atrial fibrillation. So I'll mention it. And it is important to note that people who have atrial flutter, about 50% of those go on to develop atrial fibrillation at some time in the future. People often say, how do you know that I'm in atrial fibrillation? So just a quick ECG for those of you who are interested. So our top strip is normal rhythm and distinguished by 2 distinct little blips on our screen. So the first one is the P wave, and it represents the atrial contraction. The larger spike is the ventricular contraction. And you'll notice there's 1 P wave and 1 ventricular contraction. So diagnostic of normal sinus rhythm. In atrial fibrillation, we no longer have that defined P wave or defined atrial contraction, and we have what's called a wavering baseline, and the ventricle beats are irregular now rather than being at a regular schedule, and there's no defined P wave for the atrial contraction, very diagnostic of atrial fibrillation. Often when we talk about atrial fibrillation, we refer to the ways that it presents. Fundamentally, it's the same abnormal rhythm, but it presents in different ways. So if you have paroxysmal atrial fibrillation, these are episodes that come and go on their own. And we say they usually stop on their own within 7 days. And depending on how often these paroxysmal atrial fibrillation episodes occur, we can reduce with either treatment or medication. Persistent atrial fibrillation is atrial fibrillation that lasts longer than 7 days and does not stop on its own, and usually requires treatment or medication to keep the heart in normal rhythm. And permanent atrial fibrillation is when it's not possible to get back to normal rhythm, and the treatment then focuses on medications and symptom control. So really keeping the heart rate under control and getting quality of life back as best as possible. It's important to note that atrial fibrillation, often when it starts, does come and go. Initially, paroxysmal atrial fibrillation, and over time, over a year, sometimes over many, many years, it can develop into persistent atrial fibrillation. And if you've had persistent atrial fibrillation where you've been in AFib for, you know, longer than a couple of years, often then it is very difficult, if not impossible, to get the heart back into normal rhythm. So we say that atrial fibrillation is a chronic illness. Once you've had one episode, we know you're at risk of having another, but we never know what that time frame will be. Some people have one episode and don't have another for years. So when we look at the symptoms of atrial fibrillation, we see people having symptoms. On the one hand, a person who's diagnosed incidentally having an ECG done maybe as a routine or pre-procedure and found to be in atrial fibrillation, but they really had no symptoms at all. They had no idea they were in atrial fibrillation. Then on the other extreme end, we have the person who knows the minute they go into atrial fibrillation, the heart may be racing, they may feel short of breath, dizzy, and feel unwell. And then, you know, many people fall somewhere in between, in the middle somewhere. Common symptoms are palpitations, shortness of breath, dizziness, fatigue, can make you feel anxious because your heart is racing, or you may feel unwell, or just that funny feeling in your chest. If you have chest pain though, we do say that you should go to the hospital to be assessed. We really have no way of knowing without an ECG and blood work whether you're having a heart attack. So we normally say call 911 if you're having chest pain with your atrial fibrillation. So what causes atrial fibrillation? We know certainly there are some other heart problems and lifestyle things that put you at higher risk. I sort of divided them into two categories, and with one looking at the modifiable risk factors. But we know that anything that increases the work of the heart, like high blood pressure, being overweight, sleep apnea, these things all increase the workload of the heart, and over time can cause stretching and cause the cells to become more irritable. So some risk factors are coronary artery disease. So if you've had a heart attack, a stent, or you know you have some blockages in the arteries in the heart. If there's any disorders of the valves, if you have lung disease like COPD or severe asthma, if you've had open heart surgery, we know in the first few months after, you're at higher risk of having atrial fibrillation. And as I mentioned before, if you have had atrial flutter in the past, you're at risk of going on to develop atrial fibrillation. Any abnormality in the heart structure, or simply being over the age of 60 puts you at higher risk. So now I'll look at the modified risk factors, and these can be very important in the development of atrial fibrillation, and we know that the management of these risk factors can make a difference in the progression of atrial fibrillation from paroxysmal to persistent to decreasing the number of episodes and increasing the time between episodes. That said, we have also a group of population who are young and they have no known risk factors. They have none of these, they're not overweight, no high blood pressure, such. We call that lone atrial fibrillation, and we know there probably is a genetic combination as well. So for some of you, these modifiable risk factors may or may not apply. But if you have high blood pressure, keeping good blood pressure control. If you're diabetic, keeping your blood sugar under control. If you are very overweight, we know that getting your BMI to 27 can help with the incidence of atrial fibrillation. And if you drink more than 1 or 2 drinks of alcohol a day, cutting back can make a difference as well. There was a study done on people who drank more than 10 drinks a week, and when they were asked to abstain, they actually had longer time to recurrence of atrial fibrillation and less episodes. So we say 1 drink a day for women and no more than 2 for men. And there's probably some indication that less is better for atrial fibrillation. Another factor sometimes is thyroid disease. So one of the tests that we do when you're diagnosed with atrial fibrillation is called a thyroid stimulating hormone test, or TSH. And we know that if the thyroid is overactive, it acts as a stimulant and can provoke atrial fibrillation. And sleep apnea is also an important modifiable risk factor, and I'll talk about that in a few slides. So how do we diagnose atrial fibrillation? Well, really, we have to find the atrial fibrillation on an ECG. Sometimes people have had palpitations for years that have never been diagnosed, and it can be if the episodes come and go, or if they're relatively short. Sometimes they don't last long enough for us to find on ECG, because it's gone by the time you show up in emergency or they get you hooked up to a monitor. So sometimes that can be a bit tricky. But when you do have that diagnosis and you come see a physician, you know, we'll do a health history, we'll look at those modifiable risk factors for atrial fibrillation, and we'll make sure you've had a TSH done, and we'll ask you questions about your quality of life with atrial fibrillation. And this is an important thought, and just something for you to keep track of, because really how the episodes affect your quality of life, and you know, whether they stop you from doing the things that you want to do, or whether you don't know you're in atrial fibrillation. This all plays an important factor in how we go about treating your episodes. So sometimes, or often, we'll do a Holter monitor or event recorders. These allow us to do a couple things. The event recorder is worn over 2 weeks, so this gives us a better chance of catching your palpitations if an individual ECG doesn't show it. It also allows us to maybe be able to correlate your symptoms with your episodes of atrial fibrillation, because you'll be asked to click on a button when you feel symptoms. So it allows us to make sure that your symptoms are being caused by your atrial fibrillation and maybe not something else. And sometimes the Holter monitor that you wear for 24 to 72 hours. We often do this in people who are in atrial fibrillation all the time, and it allows us to see what the average heart rate is. And this is what is the heart rate over the period of time that you're wearing the Holter monitor, to make sure that the heart rate is under control and not beating too fast. We also have an implantable loop recorder that goes just below the clavicle for people who have, you know, palpitations that only happen rarely, like once a year or so, and we can't catch, but it's worrisome to the patient, and it can be worn for a prolonged period of time. Other testing that we do is an ultrasound of the heart called an echocardiogram, and this creates a picture of the beating heart. It uses sound, and it allows us to see the size, the function of the different heart chambers, the thickness of the muscle, and the functioning of the heart valves and the blood flow through the heart. It gives us some important information. We look at the size of the left atrium. That can be an important factor if the doctor is considering doing an ablation, because if the left atrium is very enlarged, we know it can decrease the success of a procedure. And we also look at the functioning of the left ventricle, often referred to as the EF, or ejection fraction, and this tells us how much of the blood in the left ventricle is pumped out with each contraction. And this is a good indication of how well the heart muscle is working. Other testing that we may do is a sleep study. So we'll ask you different questions like, do you snore, or does your partner complain that you snore? Do you stop breathing in your sleep? Do you have unexplained tiredness or headaches? And, you know, depending on how you answer these questions, it may be worth a conversation with your physician to see if you're a good candidate to have a sleep study done. We do know that people with sleep apnea that is not treated are 2 to 5 times a greater risk of having atrial fibrillation than somebody who does not have sleep apnea. And we think it's probably related to changes in the pressure in the chest, changes in the electrical activity, and decrease in oxygen levels during the period when you stop breathing. So diagnosis and treatment is very important. It increases the recurrence of atrial fibrillation, and it can decrease the long-term success of catheter ablation. So my recommendation is always to people, if you have sleep apnea and you're prescribed a CPAP machine, to wear it. And I know people have problems with it, but it is worth some persistence in the matter. So how do we treat atrial fibrillation? So there are 2 major overall goals. One is to improve your symptoms, and the second is to reduce your risk of stroke. And really the methods or how much we do to control your symptoms really depends on how much it affects your quality of life and how severe your symptoms are. It is important when you have atrial fibrillation, or if you're in atrial fibrillation all the time, that the heartbeat does not become too fast. And when we talk about the heart rate, we're talking about how fast the ventricles are going. We know when you have atrial fibrillation, the atria are quivering and the rate, you know, is very fast, you know, 400 to 600 beats a minute. So we're talking about controlling the rate of the ventricles. And we know that if your heart rate is elevated over days, weeks, or months, it can cause that left ventricle to become weak over time. So even if you have minimal symptoms, it is important that we have your heart rate under control. Now, if you have, you know, short episodes that come and go within, you know, a few hours, or, you know, up to a day or 2, then we don't worry about, you know, any damage to the heart, but over long periods of time, that's a consideration. So there are 2 main ways that we treat people who have symptoms with their atrial fibrillation. One is rate control. So these are medications that slow down the rate of the ventricles when you're in atrial fibrillation. It doesn't stop the AF, but often just slowing down the heart rate makes people feel better and able to do more of their usual activities. So often this will be the first treatment that's tried. The other thing we look at is medications or procedures to control rhythm. So if either rate control doesn't work, or if people still feel well even after their heart rate is under control, then we look at trying to get somebody back into normal rhythm, normal sinus rhythm. And this can be either with medications or procedures such as electrical cardioversion or ablation. And it's important to note that, you know, many people have very little symptoms with their atrial fibrillation. So really, you know, over time will not need many treatments. And, you know, one person's experience with atrial fibrillation, you know, will not be another. And I'm going to talk about different, you know, medications and procedures to treat atrial fibrillation. And, you know, many of you may never need anything other than rate control medication and medication to control your risk of stroke. So rate control medications, so these are usually medications that you take every day. The Three different classes of medications. The first two are probably the most common. So the beta blockers, the LOL medications such as metoprolol and bisoprolol, and then calcium channel blockers such as diltiazem, known as cardizem, and sometimes verapamil. And then sometimes a third type of medication called digoxin is used. And these are all to prevent the ventricles from going too fast. And if you remember from the video, there's that junction box between the atria and the ventricles called the AV node. And the beta blockers slow that the conduction rate through the AV node to prevent your ventricles from going too fast. Now, some of these medications can cause side effects. The beta blockers often can make people feel tired. Usually it's worse at the beginning of the treatment and does subside over time. Calcium channel blockers can cause swelling in the feet. And, you know, sometimes it's a bit of a trial and error between different medications or classes of medications to see what provides the best symptom relief from the atrial fibrillation without causing too many side effects. So one medication that works well for another may not be the best for somebody else. So these are rate control medications usually taken every day. So the other approach is rhythm control medications. So these are medications that the goal is to keep you in sinus rhythm. So they're to prevent recurrence of episodes. So different types of medications are flecainide, propafenone, sotalol, and amiodarone. And the medication that the doctor decides is best for you will depend on both your symptoms and your health history, whether you've had any coronary artery disease or whether you have any decreased functioning in the left ventricle. That will play an influence on what medications are best for you. Amiodarone would be our most effective antiarrhythmic. It does require the most monitoring, some blood work for your thyroid function and liver and kidney function tests, a yearly chest x-ray and eye exam as well. So, you know, definitely manageable, but does require a little more monitoring. Some common side effects are nausea, especially at the beginning. If you start out on what we call a loading dose, people may have a lot of stomach upset. That often is better once the dose is decreased. And amiodarone takes a while to build up in the system, in your blood. So sometimes the dose is started out at a higher level and decreased to get your blood levels up. And amiodarone also makes you sensitive to the sun. So there's another way to take medications for atrial fibrillation, and this is called pill in the pocket. So some of our patients only have episodes once in a while, like every few months or maybe a few times a year, that are often highly symptomatic and bring them into emergency for an electric cardioversion. So the goal with pill in the pocket is to give people more control over their episodes and manage at home so they don't have to go to emergency. This can be a combination of rhythm control and rate control, or one or the other, depending on the medication. If it's a medication like flecainide, usually you'll be asked to take the first dose in emergency. So the doctor will give you a prescription. When you feel your symptoms of atrial fibrillation, you go off to emergency with your medication and say, you know, here I am, I have AFib, I have my flecainide, but I need to be monitored, and they'll put you on the heart monitor, check your blood pressure. And then if the medication is effective in returning you to normal rhythm and you don't have any adverse reactions, then the next time you can take it at home. Sometimes some of the physicians will also, if you're on a rate control medication, may say, okay, when you feel symptoms, take an extra dose of your rate-controlled medication. But of course, this needs to be discussed with your doctor. And if you're doing the pill in the pocket method of treatment, obviously, if you feel unwell while waiting for your atrial fibrillation to go away, you should go to emergency, or after 6 or 8 hours, if you're still in atrial fibrillation, then you should go off to emergency, or follow any specific directions that your doctor gives you. So another way of dealing with symptomatic atrial fibrillation is an electrical cardioversion. So with the electrical cardioversion, you're given a short-acting anesthetic, so you're asleep, you don't feel anything. As you can see, we put 2 pads on the chest and you're on a heart monitor. And the idea is we give a small electrical shock that just momentarily stops the electrical activity in the heart. Sort of think of it as rebooting your computer. And the goal is to give your sinus node a chance to come in and take over as a natural pacemaker, again, to sort of override the atrial fibrillation. And we know we do a good job of getting people back into normal sinus rhythm, but it's not curative. But we know the atrial fibrillation will come back at some point. Could be days, weeks, months, sometimes years. Sometimes people come in, they've had an episode of atrial fibrillation, had a cardioversion and emerge, and then don't have another episode for a number of years. So it's not possible to know how long the normal sinus rhythm will last. You can have the cardioversion done in emergency if you show up in AFib and you're not feeling well. If that's the case, the doctors will want to know either that you've been in atrial fibrillation for less than 24 hours, or that you're on blood thinners already and are taking it every day. If you're not on blood thinners and you've been in atrial fibrillation for longer than 24 hours, or it's unclear how long that episode may have lasted, then normally they'll put you on blood thinners and delay the cardioversion for at least a month, and that's to reduce the risk of stroke. If you're taking blood thinners and you haven't missed any doses, then we know it's safe to do a cardioversion in that case. So I'm just going to show you a video on a catheter ablation. So my next video is from the Cleveland Clinic, and it does a good job of showing what we do for a catheter ablation, which is our most invasive procedure to deal with atrial fibrillation that's causing symptoms.
The atrial fibrillation, obviously their lives have been affected. Some patients can be very symptomatic with atrial fibrillation. It can interfere with their ability to do daily activities. So ablation as a means of controlling and settling down this atrial fibrillation can vastly improve those patients' lives.
We know the initial trigger, the initial spark or the initial firing for atrial fibrillation tends to come from the pulmonary veins. And these are the 4 veins that are draining blood that has just gone through the lung and picked up oxygen back to the left side of the heart so it can then be pumped everywhere it needs to go. There's little muscular sleeves that line those veins, and those muscle cells, for whatever reason, in select individuals can act in a very irritable fashion where they fire very, very rapidly. And that tends to serve as the initial spark that sets people off into atrial fibrillation, shorting out the entire chamber. Medicines, when we use them as an approach to the management of atrial fibrillation, try to calm down that irritability. When the medicines are ineffective, and we're going to take the patient to the next level of our therapeutic approach and go for an ablation procedure, what we're doing is burning or ablating the tissue around those veins to ultimately turn that tissue over into scar. Scar doesn't conduct electricity, therefore if there's electrical firing within the vein, that electrical firing can't exit the vein and short out the entire chamber.
So essentially, a catheter ablation is similar to a heart catheterization, which most patients are probably familiar with. Typically at the clinic here we use 3 or 4 catheters that have different functions. What we do is we put those catheters through the groin all the way in the heart. One catheter is, for example, an intracardiac ultrasound so that we can see what's going on inside the heart. Another catheter is the ablation catheter. And then we have a catheter which is the mapping catheter so that we can look at the electrical activity inside the left atrium. As we cross to the left side of the heart, the left atrium, this is where actually most of the action of atrial fibrillation happens. And we use the mapping catheter to see where the electrical activity is and how much electrical activity is around the pulmonary veins. And we use the ablation catheter to cauterize and eliminate this electrical activity and to confirm that we have isolation of the pulmonary veins so that the impulses that come from the pulmonary veins don't make it to the left atrium and therefore maximize the chances of keeping the patient in normal rhythm.
We don't use general anesthesia usually. We use something called cautious sedation, and they're comfortably sedated, usually.
So at the Heart Institute, actually, we do use general anesthetic for most of our patients. The procedure takes about 2 to 4 hours, and you're in hospital overnight. If you're not on blood thinners already, usually you need them before and for a period of time after. And the goal is to, give a person a period of time, when they have less symptoms from their atrial fibrillation, maybe get off some of the medications. Again, it's not a cure for atrial fibrillation, but it's another way of managing symptoms. The success rate depends on whether your atrial fibrillation comes and goes on its own or whether you are in atrial fibrillation all the time, in persistent atrial fibrillation. We say somewhere, between sort of 70 to 80% effective for paroxysmal atrial fibrillation and, maybe sort of 50, 60% for somebody who's in persistent atrial fibrillation. And that can improve with a second procedure. About 25 to 30% of patients need a second procedure. If during the healing process, any of the cells that have been ablated or burned recover, then they can conduct an electrical signal again, and the atrial fibrillation can make it through that, fence that's been burned around the pulmonary veins. So again, the doctor, when you're having this discussion, will give, his, best prognosis. In your case, it depends on how large the left atrium is, and other, fitness, health issues as well, and whether the atrial fibrillation comes and goes on its own. So I put together a sheet for people who are thinking about the ablation and whether, they want it, whether they think it's appropriate for them. So some of the things to think about are, what are your symptoms with your episodes? How severe are the symptoms? How much does it interfere with your quality of life? The frequency of symptoms. Is it happening once every 3 years, or the episodes now have it happening, maybe multiple times a year or more often? How effective is the medications that you've been tried on? What are the side effects of medications? And, sometimes a factor is an individual's acceptance or reluctance of procedures versus medications. Some people say, I don't want any procedure, I don't want any risk, and other people, don't want to be on medication. So sometimes that's a personal, preference. And ultimately, does your physician think you're a good candidate after, the two of you have a discussion? Sometimes, the side effects of medications can be a factor in people's decisions. Sometimes our young, healthy population who doesn't have all those usual risk factors, maybe are athletic, may have a low resting heart rate, and sometimes that decreases our options in treatment with medications, because of the low heart rate, they may not tolerate medications the same as another person. So again, it all has to do with symptoms and quality of life. So now we'll look at the risk of stroke with atrial fibrillation. How do they relate? So we know that people with atrial fibrillation are 3 to 5 times greater risk of having a stroke caused by a clot, which is an ischemic stroke, than somebody without. And it's estimated that somewhere between 15 to 20% of all strokes are caused by atrial fibrillation. And for reasons that are not clear, we know that strokes caused by atrial fibrillation tend to be larger and more life-altering than the strokes that are not caused by atrial fibrillation. So why are you at risk? If you remember from the first video, the doctor talked about how in atrial fibrillation, the atria are not contracting. They're quivering, fibrillating, we say, jiggling like a bowl of jelly. And, the blood still moves from the atrium to the ventricles when the ventricles are at rest and that valve is open. But it does not flow as efficiently or as fast through the atria. And this can cause blood to pool in tiny grooves along the wall of the atria. And we also know in the left atrium, there's a tiny little pouch that you don't see in my picture called the left atrial appendage. And we know this can be a site where blood clots can form. And then from the left atrium, if there's a clot, if it should come loose, it could travel to the left ventricle, out the aorta, and then the first branch off is a common carotid artery that goes to the brain. Now, atrial fibrillation is not the only risk factor for having a stroke. Others are congestive heart failure, high blood pressure, being over the age of 65, being diabetic, obviously having had a previous stroke or mini stroke puts you at risk, or if you have a history of vascular disease. So when we look at preventing stroke from atrial fibrillation, the Canadian Cardiovascular Society devised an algorithm called CHAD65. So all doctors in Canada use this algorithm to determine an individual's risk of having a stroke. So the things we look at are the age of 65. So most people, by the time they're 65, regardless of their other risk factors, require anticoagulants to prevent stroke. Other risk factors, so the CHAD65, 65 is the age. The C is a congestive heart failure. The H is hypertension or high blood pressure. A is the age, and D, diabetes, and S for stroke or mini stroke. So the yes to any of these means that you require special blood thinners to prevent stroke. So what does it mean for you? So if you're 65, almost everybody then will require what we call oral anticoagulants or blood thinners. So they don't really thin your blood, they affect the clotting. The old standby for many, many years was warfarin or Coumadin. And then about 10 years ago, a new class of medications came out as a group called NOACs or DOACs, novel oral anticoagulants or direct-acting oral coagulants. These new medications have the advantage that they don't require the same blood testing that Coumadin requires. If you're on Coumadin, it requires at least monthly blood work to test a blood level called an INR to make sure that the blood thinning is not too high or too low. So with the new medications, we know if you take them on a regular basis, you have good protection from having a stroke. And so these newer medications are rivaroxaban, apixaban, dabigatran, and edoxaban. We know that they're at least as effective as Coumadin in preventing strokes, and that there's less risk of brain bleed than Coumadin. But people may need Coumadin if they have a mechanical heart valve or have a severely decreased kidney function. If you are younger than 65, you know, then we look at all those other risk factors. So do you have congestive heart failure? Do you have high blood pressure? Are you diabetic? Or have you had a stroke or mini stroke? So usually when we say, you know, do you have high blood pressure, high blood sugar, diabetes? What we mean is if you're taking medications for either, you know, those, if you're on blood pressure medication, or if you're diabetic, even if you're, they're controlled well with medications, that means you know, a yes to those questions. Some patients, if they've had a stent or heart disease and no other risk factors, may take aspirin or antiplatelets such as clopidogrel or ticagrelor. But we know that aspirin is not as effective as the newer medications at preventing stroke. So if you're older than 65, or if you have any of these other risk factors, then you require one of the new blood thinners. And so that this will involve a discussion between you and your doctor, between your risk factors for having a stroke and what medication he or she thinks is best for you. If anybody is on Coumadin or warfarin, we do know that there are many drug interactions and food interactions. So medications such as amiodarone and antibiotics can affect the blood level, the INR level for somebody on Coumadin. So it's important that doctors and pharmacists know that you're taking the medication, or even any medications. It's important that everybody knows. And some foods that can affect your INR, if you're on Coumadin, this matters. If you're on the newer medications, this doesn't apply. So medications that are high in vitamin K, such as green leafy vegetables, spinach and kale, can affect your INR. So if you're somebody who likes to eat these foods, we say try to keep your intake the same and consistent so we don't get a fluctuation in your blood levels. And again, only applies if you're taking Coumadin, not one of the new 4 medications. So we'll talk about how to recognize signs of stroke. I think most of you will be very familiar with these. So sudden numbness, weakness in the face, arm, or leg, especially on one side of the body, some trouble walking, dizziness, loss of balance, coordination, sudden severe headache without a known cause, sudden trouble seeing in one or both eyes. A common symptom of a TIA is actually a transient change in vision. So if this happens, even if your vision returns, it's important to be checked out. And any sudden confusion, trouble speaking or understanding. So these are all 911 calls. Any symptoms of a stroke are an emergency, and it's important that you get assessed as soon as possible. Now, it is important to sort of keep perspective that, you know, even with atrial fibrillation, if you take your medication as prescribed, the risk of having a stroke is not 0, but it's much reduced. And generally, once somebody has atrial fibrillation and one other risk factor for having a stroke, that then, you know, everything is always, you know, risk and reward, a risk-benefit scale. So once you have atrial fibrillation and one other risk factor for stroke, then we say that the risk of having a bleed from taking anticoagulants is less than the risk of having a stroke with your atrial fibrillation. So that's how we sort of balance things out. So obviously, the side effects of all anticoagulants can be increased bleeding and bruising. Some common sense things, use an electric razor, a soft toothbrush, avoid contact sports or anything where you might take a blow to your head. It's important that you let any doctor or dentist know that you're on blood thinners, especially before a procedure. It's also important that you not stop your medication though without an okay from the doctor that prescribed your blood thinner. And we generally recommend that you use Tylenol instead of what we call the NSAIDs or the non-steroidal anti-inflammatory drugs. These are the medications such as Advil, Motrin, ibuprofen for pain or fever. Those medications can increase the risk of having a stomach bleed with the blood thinner. So Tylenol is safer from that point of view. It's important to keep your blood pressure under control and that you not use alcohol excessively. So signs of bleeding, again, these would be these are severe symptoms, but blood in your urine or stool, dark black tarry stool, coughing, vomiting blood, sudden severe headache, weakness, any bleeding that you cannot stop. So for a minor injury, you would treat it as you normally would, elevate, apply pressure if the bleeding doesn't stop. Or if it's a larger injury, you may need stitches. And of course, you know, if you're concerned, go to the hospital, call 911 for a large injury. For people who are very light, like under the, 65 kilograms, under 60 kilograms, or if you're over the age of 65, heavy alcohol intake or uncontrolled high blood pressure, these are all things that put you at higher risk of bleeding, or if you have very poor kidney function as well. So some tips to live well. Many of these things we've looked at already because they're those modifiable risk factors. And if you're that person who falls in the category not having any of these risk factors, you know, you may fall into the category what we call lone atrial fibrillation. But for most of our population, we know keeping your blood pressure under control, getting tested for sleep apnea if appropriate, and wearing your CPAP if prescribed. If you smoke, quitting smoking can help. The nicotine is a stimulant. Anything you do for your heart's good for your AFib. So exercise, for most people, it's appropriate to walk at least 30 minutes a day, unless, you know, your doctor's told you otherwise. Eating a heart healthy diet, so less processed foods, more fruits and vegetables, and a lower salt diet are all important as well. And if you're diabetic, keeping good blood sugar control. And for some people, they know that alcohol can act as a stimulant. So if that's the case, you should try to cut back and at the very least stay within that healthy guidelines of 1 drink a day for women and 2 for men. And we know that for most people, caffeine is not a cause of the atrial fibrillation or, you know, even a trigger, though it can cause other palpitations. But if you find you're very sensitive to caffeine, then obviously you should cut back on that as well. It's important you take your medications as prescribed, know what they are for, what they do, and if you have any side effects, talk to your doctor. Sometimes dosages can be adjusted or another type of medication can be tried. And please consult with your doctor though before you stop any medications. Learn how to check your pulse and check your pulse on a regular basis, just so you have a, you know, an idea of how your heart rate is doing on a day-to-day basis. We say if you have symptoms with your atrial fibrillation, whether you're in atrial fibrillation all the time or whether it comes and goes, often rest can help you feel better. But if you have, you know, severe symptoms, you know, you may have to go to the hospital right away, or if the doctor has prescribed medications for you to take, you can try that. And then another slide, I'll look at some of the symptoms that should bring you to emergency as well. So to check your pulse in that soft tissue just below your thumb, that's your radial pulse. And by feeling that, you can get a sense of whether your heart is beating regularly or irregular, and how fast it is. Is it going too fast or too slow? And that can just help you keep track of whether maybe you're in atrial fibrillation, or, you know, if your heart rate is under good control. So if you come to the hospital, or even if you come just for an appointment, so make sure you know, bring your prescriptions with you, or these days with virtual visits, have a list of your medications handy when you speak to the doctor. If there's been any changes, or if you've been admitted to the hospital, we always recommend you follow up with your family doctor. And again, that's probably going to be a virtual visit these days. And make sure after you speak with the cardiologist or the specialist, who's going to do the follow-up. Is it going to be your family doctor, or perhaps a regular cardiologist, or is it going to be with the specialist, the electrical physiologist? So for symptoms, so we say if you're in the green zones, we use a stoplight tool, and I put my email address there if you'd like a copy of this, because I know it's a little bit hard to read on the small screen. But you're in the green zone if you have a normal activity level, you have no abnormal bleeding, you're not having chest pain, and you're not having too many episodes of irregular heartbeat, and no shortness of breath or dizzy spells. So this is when, you know, you're feeling pretty good. This is your baseline. And then the yellow zone is when maybe you're having more shortness of breath than normal, or you're having more episodes of your atrial fibrillation. They're lasting longer, or maybe causing more symptoms or some signs of some minor bleeding. So these would be indications to check in with your family doctor, and just maybe you need some medications adjusted. So the red zone, these are 911 calls. So any signs of a stroke that we talked about earlier, feeling that your heart is racing under control, it won't slow down. You're having that episode of atrial fibrillation, you can't catch your breath, feel like you're gonna pass out, you know, just generally feeling unwell. And any signs of uncontrolled bleeding as well. So these are emergency calls. And, you know, if you're having more minor symptoms, or an episode where you recognize the symptoms and you know they pass within a few hours, we generally say, you know, follow the instructions of your doctor if he said to take any extra medications. Or just, you know, rest, see if the episode passes. One of our physicians likes to prescribe Netflix during episodes of atrial fibrillation. But again, you know, this will be determined on how you feel. So there is a number for the hospital. If you have concerns about your symptoms and you can't reach your family doctor, or if it's evenings or weekends, you can call the Heart Institute number, press 0 and ask to speak to the nursing coordinator, and they can help you triage your symptoms. Please note though, you know, if you're feeling unwell, you're very short of breath, chest pain, if it's an emergency, call 911, and do not drive yourself to the emergency department. That happens more often than you would think. And then there's some other resources for you. The Heart Institute website has a PDF on atrial fibrillation and some videos. And also the Canadian Cardiovascular Society has put together really great resources, 3 or 4 modules for patients, a great resource for atrial fibrillation. And I put a link to the St. Michael's Hospital in Toronto. They also have some videos if you're interested in looking at some more. And the Heart Institute has also put together some great resources for either exercise, rehab, stress management, you know, during this COVID time, and when we're doing a lot of virtual visits and it's harder to see a person, a physician or other healthcare professional in person. And that's it for this Living with Atrial Fibrillation. Thank you for your time.